are good.
Excellent. No, wonderful to have you here. And I just want to see, okay, I can't see whether my video is on. I can probably, yeah. Maybe somebody else can tell me. No, I can't see it.
My video on.
Okay, good. Great. I think we can start with the introductions, just the housekeeping part at least. And then I will hand over to Dr. David Britton to introduce our speaker for the afternoon. But first, a big welcome to everybody that is here. Can I just double check that you can all hear me and see my shared screen? David, can I ask you?
Yes, I can see it. It looks very good.
You say you can't hear me. I hope you can hear me now.
I can now, yeah.
Fantastic. Great stuff. Okay, so once again, welcome to everyone. For those of you who are new with us, and this might be your first time, the weekly Monday deep dive is really open to anyone with an interest in hematology or whatever topic we have for the day. So today is now more focused on diffuse large B-cell lymphoma, but sometimes we really have topics that are cross-cutting across many disciplines, and always feel free to share the invitation with your colleagues from those areas. So in terms of housekeeping, I just want to let you know that we are recording these sessions, and recordings may be found on this website called Blood SA, which is new. This is not the VULA website anymore from UCT. Please go and have a look at this website. There's a lot of content already loaded up, and you can find it under resources. If you have any questions or answers, please add any questions or comments you have to the chat. We like this to be interactive, and we will also create some opportunity for discussion later on. There will be, towards the end of the session, a link in the chat box, which you can fill in if you need CPD points. Even if you don't, please fill it in. It helps us just with our record of attending or attendance. So that would be really wonderful. And I'm going to hand over to my colleague and the chair for this afternoon, Dr. David Britton from ACTLIFE. David is a dear and respected colleague who most of you probably know, but for those outside the hematology field, David is a clinical hematologist. He's also the leading person at ACTLIFE in Pretoria East. He's one of the leading transplanters in Africa. And David has also got a great interest in lymphoma and lymphoproliferative disorders, and is doing some exciting work on getting CAR T cells off the ground for South Africa. David, thank you very much for your time. We're also happy that David is an honorary senior lecturer here at University of Cape Town within our department and division. So an extra pleasure, David, that you're also co-chairing or lead chairing rather today's session. I'm happy to hand over to you.
Great, thanks for that, Vernon, and great to have Professor Laurie Sen here. Just reading through that bio, it looks like Canada is the right place for you, with a very strong public healthcare system. Your interest in sort of statistics and well, rather not so much statistics, but public healthcare planning and analysis seems to be the very right place for you to be. All our discussions with Matt Seftel over the years have taught us a little bit about the Canadian healthcare system. But your bio reads really well. We've broadcast it to everybody so they can all see that. But I hope that amongst your talks today, you'll share a little bit of the work that you've been doing on the biomarkers with the Lunenburg Lymphoma Biomarker Consortium. I'm hoping that that'll be something that we can all share a little bit of and see how you've how the future is going to map out, especially as the treatments get more expensive and more focused, that we can actually hopefully tailor them to the specific patients. Laurie is also an associate editor for Blood and has been on the editorial board for the Journal of Clinical Oncology and Leukemia, Lymphoma. I'm always amazed, how do you guys find enough time in the day to do all of these things and still have the clinical expertise in your field? So I think without too much more, we're really privileged to have you, and thank you for taking time out of your schedule to share your knowledge with us and to sort of help bring us up to speed in terms of diffuse large B-cell lymphoma and how we're going to manage it in the future.
Great. Well, thank you. I really appreciate the invitation. And, what I hope to do, and why don't I start sharing my slides here, is to kind of give an overview of where things stand right now with diffuse large B-cell lymphoma, because I think we all know that things just keep evolving very quickly. And I do believe that probably there are, different interpretations of the literature coming out. And I will tell you how I see things and how things are changing in my own management scheme. As with all change, it takes time to probably transpire in all of our clinics. So, one thing we're completely aware of here in Canada is that, access is not equal, not here in Canada necessarily, and not worldwide. So, the literature evolves, but we don't necessarily get our hands on everything as quickly as we like. But I think it's important to know, what is changing and what we really should be advocating for our own patients, what, is really changing the paradigm of management. So with that, we'll just go forward. And I would just say that, feel free to sort of interrupt me at any time. I'm happy to have this interactive. I know it's always hard in a Zoom format, but if people have questions, feel free to speak up, but otherwise I'm sure we'll have time at the end. So these are my disclosures. And so we all know that diffuse large B-cell lymphoma is one of the most challenging lymphomas that we treat. It's certainly one of the most rewarding, because we know that with standard treatment currently being R-CHOP, many of our patients are actually cured. But unfortunately, that leaves a proportion of patients that aren't. And the real unmet need in diffuse large B-cell lymphoma is this part of the curve here, where we know that despite our current standard of care, about 30 to 35% exhibit treatment resistance. Most of these patients do so very early. So it's an inherent chemotherapy resistance that also either manifests as primary progressive disease or early relapse, usually within 1 to 2 years. Looking on the other side of the curve, though, when we think about making progress, we also need to realize that we are curing about 65 to 70% of people now that we take down the R-CHOP route. So if we're going to try and make that curve better and add a new treatment to all of the patients, there is the risk that we'll be adding needless expense, needless toxicity to about 65 to 70% of the patients without getting added benefit. So it's been a real challenge trying to figure out how to move that curve up without added toxicity. And, needless to say that if we land up adding a treatment to all patients, we're going to definitely be adding, excess treatment to some patients who don't really need it. You mentioned predictive markers. I think that is probably going to be the number one thing that people talk about in the years coming forward for DLBCL, because it's going to be harder and harder for us to think of this curve and move the bar up for all comers when many people are doing very well, but also it's those patients with stubborn resistant disease. Probably before I move on, I'll just point out the other intriguing thing that I always find about the DLBCL curve is that historically, if we look at that later part of the curve and we think about across a population of patients, how many of those patients that basically don't get cured from initial therapy are we curing with secondary therapies? And you can see how these curves are not that far apart. So if we look at the progression-free survival curve and the overall survival curve, across a population, we're really only curing about 10% of patients historically that weren't cured up front. So I think that a big motivation has always been to improve frontline therapy, because we don't do such a great job of salvaging patients on the other end. Although, as we'll talk about, that may be changing somewhat. So it's important to keep in mind that there is a large heterogeneity when we talk about aggressive B-cell lymphoma, and particularly large B-cell lymphoma. Currently, we have been dividing patients according to some biological characteristics, and probably one of the most important changes that was made in the classification in the last 8 years was that we did separate off a group of patients based on FISH testing. So we were testing for MYC, BCL2, and BCL6, and identifying the fraction that we called the so-called double or triple hit lymphoma, whereas all of the other large B-cell lymphomas, really the majority of them fit into a bigger box that we call DLBCL NOS, which is also a heterogeneous category. Something I'd like to point out, though, is that we've had a recent iteration of the WHO classification, and also a second classification for lymphoma that came out simultaneously in blood called the International Consensus Classification. Both of these classifications have thrown out the BCL6 part of this definition. So what became clearer as we started to have gene expression profiling studies and mutation analysis, that the patients who have what we call double hit with MYC and BCL2, they do seem to be a unique biological category that is driven by oncogenes, including rearranged or changes in MYC and abnormalities in MYC oncogene that leads to what is called a high-grade B-cell biology, whereas those patients that we were defining with BCL6, particularly the double hit of MYC and BCL6, was a very heterogeneous group of patients that it's a relatively rare fraction, and I think that we don't really have a handle on whether or not those patients need to be identified separately. So the recent classifications have removed it, and really the term triple hit is probably disappearing, because the only biological distinction now is whether or not patients have MYC and BCL2. And why has it been that we've cared about this distinction? Well, you mentioned that I am a part of the Lunenburg Biomarker Consortium, and one of the things that I think is very important is to try and validate predictive biomarkers that emerge from smaller cohorts of data. So the Lunenburg Biomarker Consortium is an international effort to pool resources and patient information to try and validate biomarkers that emerged from smaller data sets or single-arm studies or individual studies. And this was an attempt to look at the clinical significance of the distinction of what we call double, at the time still referring to it as double or triple hit. So this was a study that pulled together initially over 5,000 patients, with over 3,000 patients having information on MYC, BCL2, and BCL6. And ultimately, when we looked at the outcome curves by dividing patients in the in the black curve are those patients who don't have either a MYC rearrangement or BCL2 or BCL6, so basically don't have a double or triple hit rearrangement. And if you look at the green curve, those are the patients with documented MYC, BCL2, and or BCL6 rearrangement. And we can see that comparatively, patients who are not double or triple hit historically have done much better than with R-CHOP than those that we term double and triple hit. This green curve is largely driven by the MYC and BCL2 double hit patients, because they are by far in the majority here. When we did separate out the MYC and BCL6 group, they actually fell very similarly in line with the green curve. So I think clinically, those entities had similar poor outcomes. But now, as I said, the definition has changed, and we're really looking at the MYC and BCL2 double hits as a unique biological group. And our expectations would be that if we treated those patients with R-CHOP, that they're not going to fare as well. It's not a universal death sentence, so you can see that they still have a chance of cure with R-CHOP. It's not as high as we'd like. So in most clinical settings, information like this has really propelled us to consider alternative therapies. We don't have the answer to what the alternative therapy should be for that group of patients. So we have data that suggests historically intensifying treatment for patients with double hit lymphoma may be beneficial. So most of us have translated that into our own practice. Here in British Columbia, we did move to treating all of our double hit patients with dose-adjusted EPOCH-R. Now, this started in about 2015. So recently, one of our fellows actually looked at, since we've changed treatment for double hit lymphoma to include a more intensive therapy, and in our case, dose-adjusted EPOCH-R, have we seen benefit? So one of the things I would stress to you today is that we do make changes in our treatment over time, and the only way we can really know whether or not we're making progress across a population scale is to be able to track that information. So one of the things that we do here in British Columbia, where I work, is that we do have a patient registry where we track all of our patients with diffuse large B-cell lymphoma. And we link this with our pathology information. So the goal is to have, comprehensive data on both clinical parameters and outcome, as well as pathologic information, and be able to link that data to assess outcomes and to monitor progress over time. So this was one of the studies that our registry allowed us to do. So looking back at how we've done since we switched to dose-adjusted EPOCH-R for our double hit lymphomas who are suitable to receive that type of intensive therapy, we compared it to an earlier era that was prior to when we were recommending dose-adjusted EPOCH-R. It's important to recognize that it was only when the data on dose-adjusted EPOCH-R and more intensive therapy emerged that most of us started testing universally with FISH testing. So when we look back at our historic era, it was really important to try and make sure we were comparing the same groups of patients, and we were not universally testing for FISH at that time. But we were able to retrieve the biopsies on all of those patients and do FISH in retrospect, identify the double hits from those eras, and select out the patients who clinically would have been suitable for dose-adjusted EPOCH-R. So this was not a randomized trial, obviously. It's an era-by-era comparison. And importantly, in the modern era, 2015 forward, we're getting universal FISH on all patients in real time. In the historical era, it was a retrospective compilation that we were able to extract. And, importantly, when we look at our era-by-era comparison, we can see that the patients who in the modern era are being treated with the intention to treat with dose-adjusted EPOCH-R, and not all of them ultimately get it because of various comorbidities or patients who actually have problems getting the intensity. So they don't all necessarily complete the whole course of dose-adjusted EPOCH-R, but based on the comparison of the intent to treat analysis on an era-by-era comparison, we can see that the curve of the dose-adjusted EPOCH-R has moved up notably. And so we do think, and that was true in terms of progression-free survival and overall survival, and we do think that that is ultimately translating into benefit. So currently, when we think about how we manage patients with diffuse large B-cell lymphoma, that's the one entity that we are currently treating differently. So we are pulling out those MYC and BCL2 double hit patients and treating them more intensively with dose-adjusted EPOCH-R. If they're unfit for that approach, or they are what we call in the category of DLBCL NOS, currently we have been taking them down the R-CHOP route, but of course that might be changing based on newer data. So thinking about that DLBCL NOS cohort, we know that they're also not all the same. So we've recognized for more than 20 years that there are at least 2 subgroups that can be recognized based on gene expression profiling that we've termed ABC and GCB. This is data that we do often get in our own clinic, but not using gene expression profiling because it's still probably not universally performed, although we are just about to start doing it here in BC, I would say pretty uniformly. But till now, we've relied on immunohistochemistry to make the distinction of GCB versus non-GCB, which is an approximation. But it is important because it does identify groups of patients that have different oncogenic mechanisms and may benefit from different novel therapies moving forward, but also it represents different prognostic categories. So the patients with ABC subtype have a poorer outcome than the GCB subtype when treated with R-CHOP. Recent studies have shown that it gets a lot more complex beyond the ABC and GCB distinction. So when we look at mutational analysis, we know that there's significant heterogeneity within both ABC and GCB. And this is, of course, a work in progress. We are still trying to validate some of the information that's emerged from some of the recent taxonomies. This figure is actually recently published in EPUB in Blood and represents the LymphGen distinction or classification that divides patients into probably at least 7 groups. It's interesting that despite our ability or our intention to try and classify patients into more discrete subgroups, about 40% to 45% of patients actually defy classification using this scheme. So it's in no way perfect, but it does demonstrate that even going beyond ABC and GCB, there are unique groups of patients that can be picked out based on individual mutations or groups of mutations, and that within these individual groups, we can see that patients have unique outcomes. So it opens the door for potential I would say more directed therapy, or it opens the door for the use of predictive markers in terms of our new genetic classification. But of course, this needs further validation. And beyond that, we need to create a tool that can be used reproducibly in our own clinic. So despite this great growing understanding that we have of the biology of DLBCL, with the exception of the double hit patients, I think you can make a strong argument that we continue to treat all of our patients the same, which is, of course, quite disappointing. How do we treat patients currently in our clinics? Well, we know that CHOP has been around for over 30 years as the backbone of the chemotherapy that we've used, and rituximab has been around now for 20 years, and it obviously was the last big breakthrough that we had in management because it improved not only event-free survival, but overall survival quite significantly for patients with diffuse large B-cell lymphoma and became the universal standard of care. Since that time, we've been working really hard to try and find an alternative chemotherapy strategy that's better than R-CHOP. We've attempted to decrease the interval of the cycle. We've added more intensive drugs. We've actually stepped up with stem cell transplant and high-dose chemotherapy. And in the end, none of those approaches have really made a significant impact. It's also interesting to point out that the dose-adjusted EPOCH-R strategy that I just commented that we use for our double hit lymphoma patients, interestingly, in a head-to-head comparison for DLBCL NOS with R-CHOP, did not show a treatment advantage for all comers. More recently, we've had some novel agents that have emerged that have been tested in the frontline setting to see if we can make R-CHOP better. When we start introducing novel agents, we have to be increasingly aware of whether or not those novel agents are expected to benefit all patients or just a subset. And the novel agents that have been tested to date have largely been agents that we believe are preferentially active in the ABC subgroup. So this introduced an added element of complexity, and that was the need to select patients based on a biomarker to see whether or not we can make patients with a certain biological subgroup, in this case, either the non-GCB or the ABC subgroup, better with the addition of novel therapies. So with the exception of trying to add a different anti-CD20 to the mix, obinutuzumab, which did not show an improvement, the remainder of the studies introduced drugs that included bortezomib, ibrutinib, or lenalidomide that are all shown to be preferentially active in non-GCB or ABC subgroup, and to see whether or not they could make treatment better there. And unfortunately, all of these studies fail to meet their primary endpoint. The one study I will point out, because I think it showed a very intriguing signal of benefit, and that was the Phoenix trial that did attempt to bring the BTK inhibitor ibrutinib into the frontline setting. This trial was designed again to bring in a biomarker, in this case selection by immunohistochemistry, to distinguish the patients with GCB who fell out of the study and those with non-GCB DLBCL who are then randomized to either standard R-CHOP or R-CHOP plus ibrutinib. And again, when we think about, suddenly we've got a trial that now is directed at non-GCB patients alone, and we understand that these patients are the poorer risk outgroup. So we would think that the baseline group in these patients probably should hover around the 50-50 mark of curability with R-CHOP alone. And when we plan statistics, if that's the statistics you plan for, you would power your study based on that expectation. And I think one of the very intriguing things of the study is that rather than seeing the curve down in the 50-50 mark, the baseline curve has been pushed up more to the 70% mark for this high-risk cohort of patients. So clearly introducing that biomarker did actually lead to a delay in starting treatment, whereby many patients with high-risk disease who needed immediate treatment weren't able to make their way onto the study. So these studies that have utilized biomarker selection, I would say, have also unfortunately led to an element of selection bias, where the curve, the baseline curve, has been pushed up for where we might expect it to be, which has probably limited our ability to show benefit. So overall, this outcome curve was negative. As you can see on the left, ibrutinib did not improve event-free survival compared with R-CHOP alone, but there was an intriguing signal from the younger patients. So patients less than 60 actually had a marked improvement in event-free survival, but also overall survival. Is this a real finding? I think that this is something that definitely requires further validation, as it was only a subgroup analysis and, of course, can't be definitive. But this same study was looked at recently in a more recent publication, where they actually divided patients according to the genetic subtypes that we discussed. So the more discrete genetic subtypes based on mutational analysis. And when they looked at two of the discrete subtypes that fall within the ABC subgroup, so the MCD and the N1 subtype of the mutational analysis classification, you can see here that the patients receiving the BTK inhibitor actually had a marked improvement. And you can see that they actually fall on the 100% line. So really intriguing data to suggest that maybe if you do use a biomarker to pull out the right subset of patients, the novel agents will have greater impact. So there is a trial that at least is going forward to try and validate this information from Phoenix. There are several trials out there, actually. I'm just pointing out one of them, which is Escalade, which is an attempt to bring the novel BTK inhibitor, acalabrutinib, forward, this time for patients with non-GCB as defined with gene expression profiling. So we've had real challenges trying to move the bar beyond R-CHOP in world practice. And part of that has to do with the high bar of R-CHOP. So our studies need to be fairly large and appropriately powered. If we consider that we now need to introduce novel therapies, it introduces that added complexity of potentially using a biomarker to identify our patients, which we can see has led in previous studies to selection bias, and the highest risk patients may be excluded from these kinds of studies. So some of these studies, you can argue, have been underpowered. But I also think that despite all of those caveats and issues, another part of these novel therapy trials has been that probably the biologic heterogeneity has been higher than we anticipated. And despite our ability to enrich patients based on some rudimentary tests, the complexity probably goes beyond what we're measuring and may, perhaps be responsible for us missing the benefit. So that leads us to some more recent data, and that was an attempt to move the novel agent polatuzumab vedotin into the frontline setting. Most of you are probably familiar with this drug. It is an antibody drug conjugate targeting CD79B. CD79B is a target that is universally present in diffuse large B-cell lymphoma, pretty much present on all patients' biopsies, and it's a component of the B-cell receptor. And this drug was designed to identify that target, and it has a potent microtubule disruptor linked with the compound. So when it attaches to the target and gets absorbed into the cell, it then gets dissociated in the microtubule disruptor. The MMAE causes apoptosis. So an antibody drug conjugate relying on the same toxin than brentuximab vedotin, which many of us use for Hodgkin lymphoma. So the Polarix trial was an attempt to move this drug forward into the front line because MMAE compounds can cause neuropathy as a relevant side effect. Instead of just adding it to R-CHOP, it was looked at as a replacement for vincristine. So essentially R-CHOP versus Pola-R-CHP, where the polatuzumab is replacing vincristine to avoid overlapping neurotoxicity. It is given actually as just one dose with each cycle of R-CHOP. So aim to give 6 cycles of therapy in each arm. And also there were 2 added doses of rituximab at the end of induction therapy. This was a 1-to-1 randomization and pretty much comprehensively included all comers with DLBCL. So there weren't a lot of exclusion criteria. The main exclusion criteria was that it targeted patients with an IPI score of 2 or higher. So patients with an IPI score of 0 or 1, sort of the best of the best, would have been excluded, but otherwise this was fairly comprehensive, including all comers. Looking at the baseline characteristics, this is of course a fairly large trial with about 440 patients in each arm. The median age is about 65, with patients going up to the age of 80. Fair to say that both cohorts are quite equally distributed in terms of their clinical characteristics, with a majority of patients having advanced stage disease and an IPI score of 3 to 5. So 2/3 of patients had an IPI score of 3 to 5, and a third had an IPI score of 2. Biology-wise, just as we might expect across the population, about a third had ABC subtype, and just over 50% had GCB subtype, with the remaining being unclassified. Also, we can see that about 6 to 8% of patients had double or triple hit lymphoma. So this is the primary endpoint of the trial, which was progression-free survival as assessed by investigators. And you can see that the pola-R-CHP arm did lead to a significant improvement in progression-free survival. So at the 24-month mark, and important to note that the median follow-up at the time of this analysis, which now was published in the New England Journal last year in conjunction with the ASH meeting last year. So the median follow-up at that time was 28 months. So beyond, all patients had been followed and been on trial beyond 2 years, which is important because the follow-up is relatively mature for progression-free survival, in that we know that the majority of events will happen within the 2-year mark. And if we look at the 2-year progression-free survival, it led to an improvement from 70.2% to 76.7%. So just under a 7% improvement. But importantly, the hazard ratio was 0.73. So implying that out of every 4 patients that would relapse, we're preventing 1 out of 4 relapses from occurring. Intriguingly, there was no difference in the response rates between the arms, a slight numerical difference in terms of CR rate, but not statistically different. But when we look at the disease-free survival curve, so those patients only who achieve CR, you can see that the curve still splits significantly, suggesting that there might be a deeper remission obtained by patients who receive the pola-R-CHP. This year at ASH, we will see the circulating tumor DNA data from this study presented. So that will be, I think, important information to look at. Looking at subgroup analysis, so we always look at subgroups and we sort of try and dissect these big trials to see if all patients are equally benefiting from this approach. I think there were some intriguing things that emerged. Keep in mind that the subgroup analysis are retrospective looks. They are not powered definitively to understand outcome in individual subgroups, and they're really just univariate looks. So they're looking 1 parameter at a time. Does it look like all patients benefit? And there were some intriguing groups of patients that seemed to benefit less well. For example, if patients were younger or female gender, there was less of a signal of benefit. But importantly, if patients with IPI score of 2 seem to have less of a benefit than patients with a score of 3 or higher. Patients with GCB subtype seem to benefit somewhat less than patients with ABC subtype, which is somewhat odd because we know that CD79B is present universally on DLBCL, and we wouldn't think of it to have a preferential activity based on biology. I'm not sure whether or not that's a true finding. As I said, it's a univariate look, and I think importantly, we have to wonder whether or not the biology is traveling with other factors, such as advanced stage, et cetera, that may be driving what we're seeing in this forest plot. That really will require a closer look. And also in this analysis, the patients with double hit lymphoma did not seem to benefit selectively from this approach. So again, I think these are intriguing things that we need to look at more carefully, but at this point, based on the intention to treat analysis, we saw an overall benefit. With the 2-year or just over 2-year follow-up, there was no difference in overall survival, but keep in mind it is a bit of an early time point. because we know that patients do go on to get secondary therapies. And in this trial, what we saw is that patients in the R-CHOP arm, so the blue bars, had to go on to receive more secondary therapy. So over 30% of patients in the R-CHOP arm went on to receive secondary therapies versus only 22% of patients in POLA-R-CHP. And that included therapies including stem cell transplant and CAR T-cell therapy, all of which were higher in the R-CHOP group. How about safety? Importantly, looking at safety parameters across the board, there really were no significant differences between the cohorts. So no difference in the ability to administer the chemotherapy, no differences in dose reductions required or dose delays, and across the unique set of toxicities, no significant differences were noted. So importantly, the POLA-R-CHP could be given safely. So this has led to some questions, with this data and the improved progression-free survival, which was the primary endpoint of the study. Does this make POLA-R-CHP the new standard of care? I personally, and keep in mind, this is the first trial that we've had that has universally met its primary endpoint. I personally would say that because the toxicity was not greater and that currently progression-free survival is emerging as probably the most relevant endpoint for DLBCL, because I think with our secondary therapies changing, it's going to be harder and harder to demonstrate overall survival benefit, at least in the short term. And our goal is to still, in my mind, try and cure patients and improve the cure rate in the upfront setting. I think that, this does make POLA-R-CHP definitely an option for new standard of care. Should it be used for all patients, regardless of IPI score, cell of origin? I think that is not a question that's easily answered right now based on the data we have, but it's probably something we need to look in more carefully. Does this make POLA-R-CHP the comparator for all clinical trials moving forward? Well, generally we've tried to take our best therapy and then make benefit beyond it. So I would say that trials will need to consider, this as the likely backbone moving forward. But we know that there are many trials ongoing that have been designed prior to the POLA-R-CHP data emerging. So in the future, we'll have trials emerging that still use R-CHOP as its backbone, and that might provide us with other options that are going to make things more complex if we've got a series of trials all compared against R-CHOP with benefit. So we've got the trials of the novel BTK inhibitors, as I mentioned. We've got the first line trial that's going to be examining the combination of tafasitamab and lenalidomide to R-CHOP. There are trials with bispecific antibodies being designed right now. There are even response-adapted trials trying to change track based on early response markers such as quantitative PET scanning or ctDNA, which I think will be an important response-adapted tool that we use in the future. And there are biology-driven trials being done looking at some of the genomic subsets and trying to assess novel therapies. So there'll be no shortage of trials emerging in the frontline setting that will undoubtedly make our decisions even more complex. But what about the relapsed refractory setting? We're seeing huge changes emerging there as well. It has been quite a long time that we've relied in the second line setting on stem cell transplant as the only modality that we would say previously had curative ability in the second line or beyond setting. So it was very important to distinguish who was a transplant candidate and who was not a transplant candidate, and we would take them down those two tracks. Unfortunately, even if we've deemed patients transplant candidate, they needed to prove that they were chemosensitive in order to get the transplant. So we always lost some patients along the way, unable to get the transplant. And unfortunately, despite even getting the transplant, the majority of patients land up relapsing. So despite trying to take half of the patients down the left side of this slide, unfortunately, about 90% of our patients would ultimately fall in this box, and that was what we now term transplant ineligible, that would need to go on to alternative therapies. And we would largely think of this as a more palliative approach, and patients who no longer had the ability to be cured. Of course, we do know that that is changing, and how we look at that group of patients is changing. And it's changing mainly because of CAR T-cell therapy. So there are 3 CAR T-cell products that have been approved now for probably more than 5 years in some jurisdictions. And these all target CD19. I'm not going to go through the data on CAR T-cell in great detail, only to highlight that we, after having 3 pivotal trials of 3 anti-CD19 CAR T-cell therapies emerge and come out and showing benefit. I was skeptical, I have to say, when the CAR T-cell data first emerged, to think that this was not necessarily going to be curative for the a big proportion of patients, that we were probably selecting out some of the best patients in those pivotal trials. But I think over time, what's been most initial, in the range of about 35%, which for patients who were initially entered in those trials, which was 3rd line and beyond, we wouldn't have expected those patients to have the capacity for cure. But basically with now, this is really a compilation of the most recent data from those trials, where the follow-up is now as long as 4 to 5 years. And I think it's fair to say, and time to start using the word cure with CAR T-cell therapy. What I also think has been very intriguing was we're seeing this, increasing number of real-world studies reported and looking at what CAR T-cell therapy can achieve in the 3rd line and beyond setting in the real world. This data was just recently published and was a compilation from the CIBMTR analysis, looking at a very large cohort of patients, so over 1,200, almost 1,300 patients. And they divided patients out based on clinical characteristics, whether or not they would have been candidates for those pivotal trials or not. And you can see that the outcome curves in this real world setting, looking at characteristics based on those who would have fallen out of the pivotal trials or into the pivotal trials, they actually had quite comparable outcomes. And again, what we're seeing is progression-free survivals falling in the range of about 40%, 35 to 40%, which is quite remarkable. And again, as I said, I think that, starting to be able to use the word cure for CAR T-cell therapy. So with that solid data in the 3rd line setting and beyond, it was logical to ask, should CAR T-cell therapy move forward? And could we actually replace stem cell transplant with CAR T-cell therapy? Well, we know that not all patients have equal outcomes with CAR T-cell therapy, with stem cell transplant. This is data looking at our BC cohort. So again, using our registry of all patients in BC. In this analysis, we pulled out patients who would be eligible for stem cell transplant, and looking at the outcomes with stem cell transplant based on timing of relapse. And you can see that not everybody has the same likelihood of benefit from stem cell transplant, and it is largely dependent based on timing of relapse. So if you relapse beyond 24 months, you can see that you've actually got pretty good outcomes with transplant, which is over probably 50% chance of cure. But if you relapse within 12 months of therapy, your curve is down here and under the 20% mark, and probably really here, you can see sort of down below 15%. So we now have 3 studies that have gone on to ask the question, can we replace our stem cell transplant approach? So the approach of using salvage therapy and stem cell transplant for patients with high risk relapsed refractory disease. And the definition of high risk was those who had primary progression or relapse within 12 months of therapy. This data that I'm showing you is the Axicell trial. So ZUMA-7 that used Axicell as the comparator against our standard approach of salvage and stem cell transplant. In this trial, it did probably had some element of selection bias in that patients weren't allowed to receive bridging chemotherapy. They could get steroids before Axicell, but no bridging chemotherapy. So they had to go down one route or the other. And there was no built-in crossover to the Axicell. But at the time of presentation and publication, this was the largest study with the longest follow-up, and the event-free survival was significantly improved with the Axicell approach. You can see here that the 2-year event-free survival was 40% versus only 16% with the standard approach. I think it's quite intriguing that the 16% in this high-risk cohort is quite comparable to what we see in our database here in BC. So I don't think that that was an unusual expectation or lower than expected outcome for that group of patients. It just really speaks to the fact that with our current approach of going down salvage and transplant, the majority of patients, unfortunately, are no longer chemosensitive, because in the end, only a third of patients in this standard arm got the transplant. So the majority of patients actually proved to be chemosensitive and couldn't even make it to the transplant. At the time of reporting, there was no difference, however, in overall survival, although there was a trend, and it'll be intriguing to see this follow-up reported shortly, but important to note that even though there wasn't a built-in crossover to CAR T-cell therapy, about 56% of patients in this trial crossed over to CAR T-cell therapy in the real-world treatment setting nonetheless, so it's probably affecting the overall survival curve. So I mentioned that there were 3 trials that asked the same question. They all had the same design of picking out patients who had either primary progressors or relapsed within 12 months. 2 of these trials, so ZUMA-7, as I showed you, and TRANSFORM were positive. TRANSFORM was a trial that allowed bridging therapy, so probably a more comprehensive and real-world population. The last trial, Belinda, which used Tezacel, so TRANSFORM was Lizacel and Belinda was Tezacel. It did not meet its primary endpoint, but there were some caveats in that trial. It required patients to have 2 lines of salvage before they crossed over or were considered to be an event failure. There was also difficulty getting the Tezacel and a very, very big delay in administering the CAR T to the CAR T arm, and it's possible that some of those factors may have led to the negative findings. So with the 2 studies solidly showing benefit, I would argue that the algorithm of management has changed. So both of those agents have been approved by the FDA in the United States and soon here in Canada for use in the second-line setting for patients who are considered transplant ineligible, for those high-risk patients who have progressive disease or relapse within a year. And I think you can make a strong argument that the first question now is not whether or not patients are transplant eligible or not. It's basically what was the timing from their initial therapy, and those who are primary progressors or early relapsers should be considered preferentially for CAR T-cell therapy rather than our usual stem cell transplant approach. Keep in mind that the trials that we had did isolate out what we call transplant eligible patients, but there is now data from a pivotal trial. This pivotal trial used lisocabtagene. It looked at a group of patients who would be considered not transplant eligible and looked at the use of lisocabtagene in a second-line setting, and it was shown to be effective and safe. So the FDA actually has expanded the indication for lisocabtagene beyond the randomized trials to incorporate data from this pivotal trial that now allows its use in the second-line setting for non-transplant eligible patients. So what about beyond transplant and CAR T-cell therapy? Well, it's exciting to see that novel therapies have emerged beyond for those patients who need to go on to further therapies. We've already talked about polatuzumab as it's been tested in the upfront setting in Polarix, but there are 3 other approaches that have also been approved, namely selinexor, tafasitamab, lenalidomide, and loncastuximab that have all been approved in relapsed refractory DLBCL as novel agents. I'm briefly going to mention this data because we're all in our own clinics probably starting to have access to some of these drugs and asking ourselves, who and where should we use these? So the first approval came in polatuzumab BR, and that was a combination of polatuzumab added to BR. It was compared in an initial data set against BR alone, and this is what earned it its approval, because pola added to BR actually not only improved progression-free survival, but also overall survival. And essentially in this group of patients that had relapsed refractory DLBCL who are not transplant eligible, the overall survival improved from 4.5 months to almost 12.5 months. This data was reported in a more extended format, including a larger cohort that were treated in a single arm fashion called the extension cohort, so over an additional 100 patients. And what we saw was that the data with longer follow-up from the pivotal randomized trial was stable over time, showing the stable benefit, and data from the extension cohort showed a comparable benefit with median overall survival of 20.5 months. Another novel combination that's been quite intriguing is tafasitamab lenalidomide. This is an immunotherapy approach. So tafasitamab is an anti-CD19 monoclonal antibody, and here it's added to the immunomodulatory drug lenalidomide. This is given as a more prolonged indefinite therapy. So initially it gets given quite frequently, initially weekly in the first 3 cycles, and beyond that gets given twice a month indefinitely. This trial actually had a bit of a patient selection in that it selected against patients with primary refractory disease. And that's important when we think of the outcomes that they showed, but very encouraging outcomes with a complete response rate of 40% and an overall response rate of 60% for a median progression-free survival of 11.6 months. And importantly, I think what's most intriguing about this data, if we look at the group of patients that achieve the CR with longer follow-up, those patients are doing quite well. You can see up here in the higher curve with survivals and even a questionable plateau on the curve getting out to the 4-year mark. So I think this is still a data that's quite intriguing, but would be nice to see validated in a real-world setting. Briefly, I'll just mention selinexor, which was another drug that was approved in the relapsed refractory setting. This is an XPO inhibitor. It's an oral drug. It leads to nuclear export blocking and the buildup of tumor suppressors within the nucleus. This trial, I'd have to say, although it led to approval of this drug, it's an oral drug that is intended to be given indefinitely. The trial did have some selection parameters whereby it did select a relatively better risk cohort, but despite that, the overall response rate was somewhat modest, under 30%, and the median progression-free survival only 2.6 months. So I think it's a modestly effective agent that most of us have not had access to as a single agent because it's not yet been approved in many places. And then finally, the last drug that's been approved just recently is loncastuximab tesirine. This is an antibody drug conjugate targeting CD19 with a combination toxin that is a DNA intercalator, essentially. It's a PBD dimer, and intriguing data in a high-risk cohort, meaning patients with third line and beyond, so probably the new unmet need group of patients, and given initially essentially quite frequently every 3 weeks, and then extended to an every 3-month treatment, we can see that it actually had quite reasonable benefit with an overall response rate just under 50% and a CR rate of 25%, and a progression-free survival, as you can see here, a median of just under 6 months. The last thing I'll mention as I wrap up is probably what we're really looking forward to is the next important thing happening to diffuse large B-cell lymphoma, and that's the emergence of the bispecific antibodies. So there are many bispecific antibodies in development. The ones that are furthest along in development are targeting CD20 and CD3. So we've got a few in development, and they've all been reporting data recently at the last set of meetings at EHA and ASCO. This was the data that was reported at EHA looking at epcoritamab in patients with multiply relapsed aggressive B-cell lymphoma. So this is third line and beyond data. And you can see from the waterfall plot, remarkable benefit with an overall response rate of 60% and a CR rate of 40%. And this is the pivotal data that was presented at ASCO of glofitamab. Again, here, this is a third line plus patient cohort with similar response rates of 50% and a CR rate of 39%. But you can see here from the progression-free survival curve that although follow-up is still relatively short for these agents, we're getting out to the 18-month mark and beyond, and some patients are maintaining response, with the median progression-free survival here being 12.6 months. So with that, I'll just summarize to say that for DLBCL, moving beyond R-CHOP has been a real challenge. Finally, with the POLARIX trial, we do have a combination that is similar safety profile, but has shown improvement in progression-free survival and will emerge as a new standard of care option. There are additional trials being done, however, in the frontline setting, and undoubtedly that will lead to added complexity moving forward. I think that CAR T-cell therapy, despite the caveats of the difficulties with access and expense that we're all grappling with, it has emerged as a potentially curative therapy in the third line and beyond setting. But now we've got data in the second line setting to suggest that it should be the preferred approach for our transplant ineligible patients or are patients who are transplant eligible but high risk, meaning primary refractory or relapsing within 12 months. And then, of course, with all of these options available, and particularly the growing list of novel therapies in the relapsed refractory setting, probably the most important thing moving forward is going to be for us to identify predictive biomarkers to identify who is going to selectively benefit from some of these treatments, because I'm sure that South Africa is very much like Canada. We're not going to be able to offer all treatments to all patients. So our real goal is to try and maximize our resources and select the right patient for the right, the right treatment for the right patient at the right time. And I think that, that's going to be the next big challenge for diffuse large B-cell lymphoma. So with that, I will end there, and I'd be happy to entertain questions or any comments that you might have.
Sure, Laurie. I didn't know there was so much to know, should I say. It was a great overview of where we are and where we're headed. And thank you for that. Just a little note from Vernon is to register for your CPD points. But as he mentioned earlier, just to access the website and also just to register with anyway, just to show that you were here. Can I ask you to expand perhaps a little bit on something that you mentioned earlier, is the, by profiling patients, that maybe we can, especially in a condition where a large number of patients are cured, are there ways to reduce the toxicity of the frontline therapy, similar to what we're starting to see in Hodgkin lymphoma? Now, the results are not up there, but they're not bad. And so maybe out of the 70% so that we're curing, there's a significant percentage of people who could actually do with less therapy. And we're obviously always a little bit nervous of that, but do you think you could expand on that a little bit?
Yeah, I mean, we've seen in Hodgkin lymphoma where the curves have gotten so high that we've been able to start whittling back and trying to eliminate toxicity. And we've seen trials designed to, remove agents and minimize toxicity. I think in DLBCL, because upfront therapy has been so important, and what we've been able to accomplish in the second line and beyond setting has been so dismal that nobody's been willing to try and pull back on the therapy. We know from our own patients who are elderly or frail or not suitable for R-CHOP that we do have many patients that are cured with less than R-CHOP. So here, for example, if patients have cardiac comorbidities, we take out the doxorubicin and we use etoposide, and our outcomes, I think that's a bit of a compromise, but the outcomes are not that far off and are fairly comparable to suggest that even the anthracycline may be expendable for some patients. So I think you're making a very important point. I have to say that, I still think it's very hard to start whittling away at R-CHOP. I think Polarix obviously replaced one of the agents, but we obviously think vincristine is probably the weakest link. And based on, the encouraging data of polatuzumab, it didn't seem to be too much of a risk to remove vincristine and put that in there as a test, but to peel back on other elements, I think, most of the trials are sort of keeping the backbone intact and trying to add to it, which does, limit probably what you can do, because we do worry about additive toxicities. But, as you say, it probably is going to take us to get a little bit smarter and to be able to start really pulling out, the patients who are, doing super well or won't benefit from one particular agent. And I think that's going to be difficult.
I think also to go on the other side of the spectrum, for those of us, and they're not that many anymore, who are old enough to remember, but CHOP could not be beaten by MACOB-B and, all those really intensive regimens, mine, ESHAP and stuff. And so going harder, it also doesn't help for the high-risk patients, and we need to have smarter drugs. There's a question from Perry here, Perry Lubenberg, who asks, in the absence of CAR T therapy, would you recommend investigating options for allogeneic transplant in these patients that relapse early? The problem obviously being that you've got to still get them into remission. But
so we have not used allo very much at all in our institution. I think the problem is that, across the board, this is a group of patients that sometimes age alone makes them not, desirable candidates for allo. But I do realize that people have pushed up their allo age quite significantly in the recent past. I think the biology of DLBCL in many patients doesn't lend itself to, to an allo, in that you have to have time to set up the allo and find a donor. And when you've got very aggressive biology, so the worst of our worst patients, really, their disease evolves very quickly. And the biology itself might not be suitable for what an allo can offer. So I'd say that, I don't know where allo should fit in at this point. I think that in our own clinic, we're not going to allos. I'd probably prefer to go to a novel agent or even a clinical trial in many cases ahead of allo. I just think that, the allo is not often feasible. And even then in these higher risk patients, I don't know that it has the ability to, achieve cure in our worst patients. Having said that, we know that, there's some patients that have been cured with allo, but, who those patients are that should be selected for that, I think is hard to say, and how to match allo up against some of the novel options. I think that most of us would definitely go to CAR T ahead of allo if it were accessible.
Yeah, I mean, we went through a phase before where primary refractory patients would be considered for an allo. And I think we would still do that because we often don't have access to novel therapies. And our experience with accessing these things takes too long. Karen makes an important point here that, one of the issues with BiTEs and CAR Ts is that you need to do them before you've completely annihilated the patient's T cell compartment. So one needs to consider that. And Farah asks a question, do you know of any experience in using these agents in patients with HIV? We have a significant proportion of our diffuse large B-cell patients being HIV positive, maybe even as many as 50% when you look at the numbers, how they've grown in the HIV era. And these patients tend to present with particularly aggressive disease, often extranodal disease, and high incidence of CNS involvement as well.
I think you're raising a very good question, and it sounds like it's highly relevant for your patient population. It's typical that, when we see these agents being tested, I'd say that pretty much universally HIV positive patients have been excluded from all of the trials. So I think that we will likely see that data emerge from real world analysis, but right now, I don't think we can rely on the clinical trials to provide safety information for that patient cohort. But, in our own, as it rolls out in terms of access, it certainly is not going to be exclusionary. So, I expect that I will be able to use all of these options as they become available here in Canada in my HIV positive patients. And I think that it'll be a universal learning curve for all of us. And I hope that real world data will be emerging somewhere probably ahead of what we can generate here in Canada, because as you said, we have the same lag of access here. And so hopefully we'll see that data.
Yeah, I mean, our experience with selinexor and blinatumomab in the HIV, not in the HIV, in the relapse refractory diffuse large B-cell setting was fairly disappointing. Can I ask you about CNS lymphoma though? I mean, what is the experience in using drugs like polatuzumab and CAR Ts in patients with CNS disease? I mean, the CAR Ts are CD19 targeted, so perhaps that's, but polatuzumab?
Yeah, so I'm not aware specifically of any data in CNS with polatuzumab, but it is a fairly sizable molecule that wouldn't be expected to cross the blood-brain barrier. So I wouldn't expect it to have any kind of major impact. It's interesting, I haven't seen, and I'm sure this will be looked at, it might just have been a little early, we'll be able to see if there's any difference between the two arms in Polarix in terms of CNS prophylaxis with one, see if there's any differential impact. I'm not aware of any to date, but I also don't know that data has come up. So I don't think polatuzumab is going to have a big role to play in CNS, just based on our expectations. For CAR T cell therapy, there is data to suggest that it can affect CNS disease. So there are some basically real world cohorts that have been published as case series, and there's at least one, if not two, phase 1 trials that now have been reported, one in Blood recently, looking at CAR-T for CNS involvement, and there has been modest benefit shown, but I think it's still small numbers, and it looks like it's transient benefit. So I don't know how many people will have prolonged benefit with CAR-T.
I think I know we're going on a little bit, but there's still some interest, and a lot of people are asking questions. So Vernon asked the question: are there any biomarkers to indicate a high risk for CNS prophylaxis? I mean, CNS relapse, and the group of patients that we could, outside of the current clinical markers, that we could indicate should have CNS prophylaxis.
So I wouldn't say that there are reliable biomarkers. So there's been data, we looked at data to suggest that ABC subtype had a higher risk, and others have shown that as well, or the non-GCB subtype is a higher risk. But overall, I think that we have basically the CNS IPI that pulls out about 12% of patients having the highest risk, and that's about a 12% risk. And you'd argue, is that high enough? I'm not really sure. I think there's two big questions that have emerged, right? Can you pick out a high-risk patient, and can you actually do something about that to make a difference in their likelihood of relapse? And I have to say, I'm becoming more and more skeptical. So although probably the CNS IPI is the best that we can do, and that still leaves you with 12% of patients that are the highest risk at 12%, is that high enough to justify giving them higher toxicity? And keep in mind that more patients actually have CNS relapse that are not part of that fraction if you look statistically. So I don't think there's a biomarker or a perfect parameter. In our own clinic, the only patients we have been considering for CNS prophylaxis are what we call the highest of the high. And I think that those are patients with primary testicular or renal adrenal involvement, where there's a lot of data to suggest that their CNS relapse risk is over 20%. So those are the only two fractions where we've considered giving CNS prophylaxis. Although I have to say that, at the last two ASH meetings, there's been a lot of, unfortunately, we don't have randomized data or comparative data, but retrospective data that is really calling into question whether or not we're making any impact with our CNS prophylaxis. So I think that I am probably using it less and less, even for those high risk patients, the patients who I thought were marginal and maybe, were not great candidates. I'm now no longer giving it to them. And the only ones that I would consider are, really the robust patients with primary testicular or adrenal. Keep in mind, I did want to point out an important study in Blood this year, that when we gave the CNS prophylaxis, we used to use modest dose methotrexate at 3.5 grams per meter squared and try and give 4 treatments kind of intercalated between R-CHOP and then 2 at the end. And there was a study in Blood that suggested it didn't matter if you gave it during R-CHOP or at the end of treatment. It doesn't tell us if it works. It just tells us that it doesn't matter if you delay it till after R-CHOP. And I think that's important, because I no longer give it in the middle of R-CHOP, because I think the last thing you want to do is derail the treatment that we know works and that the patients need to cure their systemic disease. So if I gave it, I would absolutely give it after the R-CHOP is complete, and only to those patients achieving a complete response.
Yeah, that's a good point. Garrick asks us, well, firstly, thanks you for an excellent talk and impactful talk. But he also asks, is there still a role for double hit identification in the kind of era of being able to do genetic profiling and categorizing of the patients based on their genetic GCP.
Yeah, so I think if we imagine that we will all ultimately move into the genomic world, probably FISH testing won't be so necessary in that, you know, through genomics, you can actually identify what I referred to earlier as this high-grade biology that includes the patients that we're currently identifying with MYC and BCL2 rearrangements. It actually goes beyond that. So, you know, definitely MYC and BCL2 FISH testing is still kind of a rudimentary test to identify biology. And what we have recognized from data that emerged from my colleague, Dr. Scott, here in Vancouver, as well as others, and a nice UK study, that there's a group that can be identified as having similar high-grade biology using genomics to these double hit lymphoma patients that we identify with FISH. Basically that, you know, you can identify about double the patients using genomics that have a similar genomic profile and similar poor outcome. So I think that identifying them with FISH alone probably, you know, allows us to miss a proportion of patients with similar biology. So I think in the future, we will move toward more of a genomic classification. And within that classification will be the high-grade biology that, you know, we're now identifying in a rudimentary way with FISH testing, and we'll probably double that group of patients. Probably, you know, not unlike what we currently do for CLL, you know, we can basically double the group of high risk by doing P53 mutations on top of 17p deletion. I mean, it's the same thing conceptually that, you know, that probably our genomic tests open up a broader group of patients.
Perhaps one last question. I mean, it's a hypothetical question, but is there any role, do you think, for adding IMiDs into treatments using either bispecifics or CAR-Ts in the, you know, understanding that they stimulate these cell populations and maybe would enhance efficacy and toxicity?
Yeah, I mean, I think that, you know, we're seeing with the CAR-T data and the bispecific data is the power of an immunotherapy approach. So clearly, you know, augmenting the, you know, benefit of the immunotherapy by, you know, finding logical combinations that augment that approach is really desirable. I think that data will inevitably emerge. You know, the bispecifics are being tested together with IMiDs, for example. In fact, the registration trials in the second line setting are linking them with IMiDs. And I think that in follicular lymphoma for sure, and we've got studies that are being done in DLBCL. So I think that, you know, inevitably we'll learn a lot about the combination of IMiDs and bispecifics from all of the trials that are ongoing. And I haven't seen as much in CAR-T, but I you know, I think that data will also emerge. So whether or not IMiD with CAR-T is the best approach versus, you know, other immune augmenters. Obviously, people are looking at PD-1 inhibitors and other modalities with CAR-T. But I think anything that, you know, harnesses the immune system and augments it beyond what we're showing, which is just really phenomenal, you know, and I think, you know, many of us imagined that this was possible for DLBCL, but, you know, it's really important to realize it's all of this information is new and is evolving. And I am optimistic to believe that we're going to just build from here.
Yeah, it's exciting to be part of the era of so much change and growth and optimism. So, Laurie, thank you again for your generous time and sharing your extensive knowledge. I think we got much more than we bargained for. Vernon, I can see shaking his head in agreement there. We really appreciate it. And we're finishing our day, and I'm sure that you're only heading into the tough part of the afternoon now. So
Perfect. My pleasure. Have a
If
good
I can-
evening, everyone.
If I can just add, Prof. Sen, from my side, this was really wonderful and very practical. And you could just see from the comments in the chat that everybody really enjoyed it. I do have one provocative question, more in general, please. How does your department deal with the two, well, I'm not sure if I should say opposing, let's say competing sets of classification that we've just been confronted with from the WHO and the international sort of consensus group. How do you practically deal with that every day?
Yeah, so, it's putting us all in this really, just when we thought it was hard enough to memorize one classification, now there's two competing classifications out there, and I won't even begin to dissect, how that happened. But, I think what's interesting is that they're not that far apart. So especially for lymphoma, I think that, they're closer than they are far apart. And so that's encouraging for me. I think what was a little bit different was sort of the processes that were put in place to create them. But the nice thing to see is that they did converge, I think, on a message that wasn't too different. I think, that's, we're sort of looking at all of that information, and I think it's important that we continue to kind of make sure that patients have their biology looked at by a hematopathologist or somebody that is really knowledgeable, because as you can see, it is becoming more complex as we dissect out these different fractions of patients. And even, if the terminology is not identical and the nomenclature is changing and there's competing sets, but I guess I'm encouraged that they're more similar than different. And I think that moving forward, it's likely that we'll create some kind of merged method for, sort of having a uniform classification.
Great, thank you. I'd just like to say thank you to David for a great job chairing the session. Appreciate your time, David. David is super busy as well. Really, thank you. You saw for a moment there that I shared the screen with the names of the people in the team that organizes our weekly sessions. Thank you to Prof. Stelverberg, Hadley Kritzinger, Melanie Davids, everyone helping to make this a reality, and now afterwards to put the recording on our Blood SA website. Thank you very much. And again, Prof. Sen, what a fantastic session. Thank you for your time, and we wish you all the best.
Thank you. My pleasure. Have a good evening.
Bye-bye, everybody.
Thank you. Bye.